Hello, my name is Robert Guigliano. I'm a senior investigator with the TIMI Study Group in Boston, Massachusetts. I'm a physician in cardiovascular medicine at the Brigham and Women's Hospital and also associate professor of medicine at Harvard Medical School. And I'm here today to discuss the new oral anticoagulants that are being developed for patients with atrial fibrillation as well as venous thromboembolism treatment and prevention. But today we're really going to focus on these novel agents in atrial fibrillation. Many of you are aware that new oral anticoagulants have been developed and studied compared to warfarin in large trials of atrial fibrillation. The first of these agents, dabigatran, was studied and approved in 2009 for use as an alternative to warfarin in patients with atrial fibrillation. That drug was approved on the basis of the RELY trial, which was a comparison of two different doses of dabigatran versus warfarin in an open-label study design. In the RELY study, both doses of dabigatran were non-inferior to warfarin, although the high-dose regimen, 150 milligrams twice daily, was superior to warfarin and clearly reduced ischemic stroke. The low-dose regimen, 110 milligrams twice daily, was as good as warfarin, but did not have the same impact on ischemic stroke as did the high dose. With regard to safety in the RELY trial, dabigatran 150 milligrams had similar bleeding rates to warfarin, whereas the low dose was safer and had a reduction in bleeding events. Both doses of dabigatran, however, did reduce intracranial bleeding, which is the most feared type of bleeding complication as compared to warfarin. Mortality tended to be lower with the high-dose dabigatran compared to warfarin, whereas low-dose dabigatran and warfarin had similar mortality. So we see, as of 2009, an introduction of a nice alternative to warfarin, which is easier to use, does not require routine monitoring, and has some clinical benefits as compared to warfarin. The second novel agent studied, developed, and approved was rivaroxaban in the ROCKET-AF trial. A single dose of rivaroxaban, 20 milligrams once daily, was compared to warfarin in patients with atrial fibrillation who were at moderate to high risk, and really mostly high risk. The majority of patients in ROCKET-AF had a history of prior TIA or stroke, which is the most important risk factor for predicting future thromboembolic events, in particular stroke. In the ROCKET-AF trial, 20 milligrams of rivaroxaban once daily was non-inferior to warfarin, and if you look at the time of analysis while the patients were actually taking the study medications, rivaroxaban looked better than warfarin. Bleeding rates were similar. Mortality rates tended to favor rivaroxaban, but not significantly. And importantly, once again we see that intracranial bleeding was markedly reduced with rivaroxaban. So the importance of the ROCKET-AF trial was that for the first time we have a novel once-a-day oral factor Xa inhibitor that's at least as good as warfarin. And many clinicians have now turned to this agent as an alternative to warfarin in patients with atrial fibrillation. The third novel agent developed was apixaban, which is another oral factor Xa inhibitor. This was studied in two phase 3 clinical trials. First, the Averroa study compared apixaban with aspirin in patients who were not able or not eligible to take warfarin. Apixaban was so much better than warfarin that the study had to be stopped prematurely due to overwhelming efficacy. In retrospect, this is not really a surprise, since we know from prior studies that warfarin is much more effective than aspirin in preventing stroke, and these novel agents are at least as good as warfarin, if not better, so it was not really much of a surprise that apixaban was much better than aspirin. In the Aristotle trial, however, apixaban at a dose of 5 milligrams twice daily was compared to warfarin in a double-blind trial. This study was a big win for apixaban in my view. Apixaban not only reduced the primary endpoint of stroke or systemic embolic events compared to warfarin, it also significantly reduced bleeding and significantly reduced mortality. So it's really a triple win for apixaban, with reduction in stroke, bleeding, and mortality as compared to warfarin. Importantly, we see again this common theme across the novel agents of a marked reduction in intracranial hemorrhage. That seems to be a major benefit of the novel agents as compared to warfarin, along with some more practical issues like the absence of any regular routine monitoring, fewer drug-drug interactions, and no drug-food interactions. Most recently, edoxaban, an oral factor Xa inhibitor, was compared to warfarin in the largest of the AF trials known as ENGAGE-AF TIMI 48. Two different dosing regimens of edoxaban were compared to warfarin in this double-blind, double-dummy study. Warfarin was very well managed in the study with an average time in therapeutic range of 68.4%. That was the highest amongst any of the trials. ENGAGE-AF TIMI 48 also had the longest duration with a median follow-up of 2.8 years. The main trial results were that edoxaban at both dosing regimens was non-inferior to warfarin, with the high dose tending to be better than warfarin. Both dose regimens were safer. The low dose in particular was very safe, significantly reducing major bleeding with a marked reduction in intracranial bleeding. And both dose regimens of edoxaban reduced cardiovascular mortality, with the low dose even significantly reducing all-cause mortality. There was a recent meta-analysis also performed of these four major novel agents as compared to warfarin, and is available online at Lancet. This meta-analysis was authored by Dr. Christian Ruff, and it is a nice summary of these four new agents as compared to warfarin. The key findings were that the novel agents overall clearly reduce hemorrhagic stroke and clearly reduce intracranial bleeding by 50% or so. There's also about a 10% reduction in mortality with the novel agents as compared to warfarin. And the novel agents have a more modest effect on ischemic stroke. Bleeding tends to be reduced with the novel agents, with the exception of gastrointestinal bleeding, which is increased. So we can see now in 2013 and in the future, we have a very strong set of alternative drugs that we can use in atrial fibrillation to warfarin. But I want to leave you with an important last message, and that is that the most important decision in atrial fibrillation is identifying patients who will benefit from an anticoagulant. In fact, the most recent guidelines indicate that more than 3/4 of the patients with atrial fibrillation ought to receive an anticoagulant because of their risk. So most important is to identify those patients who are at moderate to high risk and deserve anticoagulation. Then we can have a more scholarly discussion over which anticoagulant to choose. We have multiple options now to warfarin that are easier to use, safer, and don't require routine monitoring. Thank you very much for your attention.